بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وآله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما يا أكرم الأكرمين. My topic today is continuation what I discussed previously about the abnormalities of secondary pulmonary lobule, and I discussed previously the reticular pattern of involving the secondary pulmonary lobule. Today I will discuss the nodular pattern involving the secondary pulmonary lobule. As we know, we have three patterns of nodular pattern involving the secondary pulmonary lobule: the random one, centrilobular one, and the perilymphatic one, as seen in this sketch. I will discuss each one of them and each differential diagnosis. As we know, this is the normal secondary pulmonary lobule, has the central arteriole and central terminal bronchiole, and these are the septi. And here we see the normal septi, and there is centrilobular nodule. It is away from the pleural surface and can be associated with a tree-embodied appearance, as we will discuss later. The differential diagnosis of the centrilobular nodule include hypersensitivity pneumonitis, respiratory bronchiolitis, especially in the smoker, and infectious airway disease include TB and bronchopneumonia and uncommon causes. Here, as we see in this high-resolution CT scan, faintly visualized centrilobular nodule involving the secondary pulmonary nodule in patient with hypersensitivity pneumonitis. The perilymphatic nodules are distributed around the bronchovascular bundle, as we see here, multiple nodules around the septal surfaces, as we see here, and it is touch the pleura and the fissure, as we see in this image. The differential diagnosis of the perilymphatic nodules include sarcoidosis, include lymphatic spread of carcinoma and silicosis and pneumoconiosis and other rare causes. This patient with sarcoidosis with lymphadenopathy here and lymphadenopathy in the right paratracheal region and multiple nodules around the fissure, as we see here, around the bronchovascular bundle and around the secondary pulmonary lobule, in this here with septal thickening. This patient with sarcoidosis. The last one pattern is random nodular pattern involving secondary pulmonary lobule. As we see here, this is randomly distributed, not in the centrilobular pattern alone, not in the perilymphatic alone. It is randomly distributed, and it is touch the pleura as in the perilymphatic nodule, and it is also scattered in the lung. The differential diagnosis of these random pattern nodules involving the secondary pulmonary lobules are hematogenous metastasis, miliary TB, and miliary fungal infection, sarcoidosis, and early stage of the nodular pattern of Langerhans histiocytosis. Re-embodied appearance. These are appearance an irregular nodular branching structure is identified in the lung periphery and represent dilated and impacted mucus or pus in the Centrilobular bronchioles. As we see here, this is the red one, the central arteriole, and the white color, these small nodules involving the terminal bronchioles due to impaction and filled with mucus or pus or cells. The differential diagnosis, it is previously thought that it is specific for TB, but it is not. Nowadays, it is not specific and can be seen in the infection, can be seen in the allergic allergic bronchopulmonary aspergillosis and airway disease like cystic fibrosis, bronchiectasis, and infection like TB or Mycobacterium avium or other infection like bacterial or infection. As we see here in this patient, we have multiple tree embodied appearance, branches, terminal bronchioles, terminal centrilobular bronchioles, filled with mucus or cells. To sum up, as I discussed, we have three patterns of the nodular pattern involving the secondary pulmonary nodule. We have the random one. The random one, it is randomly distributed and it is touch the pleura. And the differential diagnosis, as we mentioned, metastasis, miliary TB. Centrilobular nodules are located in the central secondary pulmonary lobule, and one of the differential diagnoses is hypersensitivity pneumonitis, respiratory bronchiolitis. And the last one, it is perilymphatic nodules. This is around the bronchovascular bundle, and it is touch the pleura of the fissure, and the differential diagnosis, lymphatic spread, sarcoidosis, and other causes. As we notice, there is overlap in differential diagnosis between the perilymphatic nodules and nodular septal thickening in the reticular pattern discussed previously, and sometimes it is termed as reticulonodular pattern, sometimes used. To sum up again, if we have multiple nodules in the lung, we want to see if it is touch the pleura or it is not touch the pleura. If it is not touch the pleura, this is centrilobular in distribution. And our list of differential diagnoses include hypersensitivity pneumonitis, respiratory bronchiolitis. If it is touch the pleura, it is touch the pleura, it is we have two patterns associated with septal thickening, with septal peribronchovascular or subpleural thickening, and we have perilymphatic in distribution, and we have sarcoidosis, silicosis, lymphangitis, carcinomatosa. If there is diffuse but randomly distributed, we have miliary infection and TB fungal metastasis. Thank you very much. Hoping it will help you in daily practice.